Okay, thank you. So today my talk will be a practical Alzheimer's disease classifier. So today's point will be threefold for aims because this is an educational course. First, I will tell you how we build this deep learning classifier. And second, as we have new data that I want to convince you it really works, that on any kind of sample, any kind of scanner, that we can use this classifier to predict the future risk of Alzheimer's disease 5 years in advance. And the third, because this is an educational course, I want to ensure you, everybody here, know how to use our classifier. If you don't have any programming skills, you can use our browser to predict the Alzheimer risk, or use our DeepIB platform, use GUI. Or if you have some coding skills, you can use Docker and Python to load our model to predict by yourself. And furthermore, if you have more programming skills, you can use our pre-trained model to train your own model. Maybe we have a Alzheimer's disease pre-trained model. You can transfer learning, go to your own data set, maybe autism, maybe depression, etc. So these are the three-fourths of aims. And for the third aim, please join us this afternoon. We have a demonstration session for you how to use our classifier or how to use our pre-trained model, because our model and the code are all open source, and I will show you this afternoon. And in this morning session, that my talk will be pure structural imaging. And Paul Thompson, Dr. Paul, has demonstrated one slide that we also have cool results on using functional data using the brain informer to decipher mental states. I hope Anqi will have an opportunity to organize next year. We can show you next year. Okay, so actually this work, mostly because of Paul, I think, that this work has featured in Nature News. So Nature News said AI that read brain scans shows promise for finding Alzheimer's genes. So quoted that our work to detect Alzheimer's disease with accuracy for more than 90%. So this is a pretty good accuracy, but I want to show you it's not just we can actually detect Alzheimer's disease. The importance is this classifier can predict future risk, that you can use that to prevent that, because we know the later stage of the Alzheimer's disease, there's no cure up to now. But there's some FDA-approved medicine that at a very early stage, you can use to prevent the development of Alzheimer's disease. So this is what we want to show you. So if you are more interested here, you can read our paper published in Journal of Big Data. So basically, it's because there are so many different kinds of brain disorders. For tumor, you can use your eye to see there is a tumor. But for mental illness, like schizophrenia, like a major depressive disorder, you can only use a symptom-based clinical observation. And we hope in the future we can develop some brain imaging biomarkers, maybe for MDD, maybe for schizophrenia, but up to now, all groups have failed in developing such biomarkers. The only success is developing Alzheimer's disease classifier. So we hope in the future we can better develop for psychiatric disorders. So Alzheimer's disease, as an example, is a central nervous system degeneration disease. It has high prevalence, and the diagnosis that I think we are able to develop Alzheimer's disease brain imaging biomarker is because this kind of disease has better, less heterogeneity, and also that has this kind of objective biomarkers that using molecular imaging or CSF test. So basically, you can do a CSF, but it's invasive. Or you can use a PET, but it has injected traces. And also, in China at least, the PET scanners is not as prevalent as MRI machines. So what we want to do is using MRI machines because it can directly reflect brain structure and function, and it can short duration and no radiation. So if we can just use MR to scan brain and tell you the risk of Alzheimer's disease, it will have very high practical usage. So I don't want to repeat because Paul or Sergey or Jin has already tell you that how machine learning works. And I don't want to repeat that, but we do hope machine learning can help us. We're using our eyes, we cannot tell you exactly this is Alzheimer's disease patient. Although we can infer, seems loss of atrophy may be Alzheimer's disease, but using machine learning, the AI can tell us. And most previous studies, there's lots of studies, I don't want to repeat that, but there's important thing is the generalizability. We want the classifier can be applied to any kind of data set across the world. So you do not need to retrain the model, but use your own data to tell the risk of Alzheimer's disease. So mostly it's not big enough, not the heterogeneity size big enough. So we want to use this kind of, for validation, it's important, as Sergey also said, the overfitting thing. So mostly we use random cross-validation. That means we collect a set, and this data we also enter into the training data set. And the set information we also learned in the training data set. But sometimes when it applied a totally brand new data set, it sometimes fails because of overfitting. So what in our mind, we want to build more is independent dataset testing that need to be applied in any new dataset. And this is transfer learning. I don't want to repeat because Paul and Sergey and Jin has told you that what transfer learning is, that from a psychological perspective, and we use pre-training and we do fine-tuning. And this part is pretty important that if you're interested, you can use all pre-trained model. It's open that you use fine-tuning in your own data set. And this is transfer learning. So we have the basic first convolution layers, second convolution layers. And basic idea is we keep the lower level convolution layers, but we retrain the higher level layers. So this is a retrain, and we retrain the upper level task-specific modules. So this is our general basic idea, and this has been taught in this morning. So what we want to do is we want to build something that can be applied to any kind of data set. So that means all models should have seen most of different data across the world. And there's so many open source data. So what we want to do is using all this data, because this normal population data is very large sample size, but have limited type of demographic and clinical data. Most of them have the information of gender and age. But most useful is in the future, we build brain disease classifier, but brain disease classifier mostly have small sample size and multiple sites, strong side effect. But once we have trained, then we have a high application value. So we want deep learning to build a sex classifier in the first hand, and we use transfer learning, use this pre-trained model to do a disease classifier. Although in PNS there's a paper discussing human brains cannot be categorized into two distinct classes, male brain and female brain, but I think it is back to that time, the newer algorithm didn't emerge. But nowadays, we really can tell you the brain sex. It can be categorized into male brain and a female brain. And we use transfer learning to build an Alzheimer's disease classifier. And there's lots of previous studies doing that way. And what we want to do is medical imaging assistant diagnosis requires big data. We will see that. If you use small data, it's always overfitting. And we really want to ensure generalizability that apply to new data set. And transfer learning, we think we may improve model performance. So Dr. Binglu is here, and he applied for almost all the public data set by hand. And probably he's the people by that time processed the most different data set by himself. And we have 50,000 participants and 85 structural MR samples. And this comes from 217 sites or scanners. This is important. That means our model have seen about 217 different scanners. And later, the model can ignore side effects. It can be applied to any different new site. So this is important. I don't know how the model ignored the site inference, but it can do that. And this includes 34 data sets. And the processing is pretty simple. We have developed our DeepIB software and the DeepPass software is based on SPM. So what you need to do is use all software or just simply use SPM to pre-process your data, have a gray matter volume and a gray matter density. So this is our structure of the CNN model. And Sergio has told you the building blocks. It's pretty complex. We have the STAR model. So this is basically the Inception ResNet V2, but Inception ResNet V2 is a 2D model, and Paul has told us that we can transfer the 2D model into a 3D model. So we replace the 2D to 3D. You have a stain model, and we have the reduction model. So basically, input is gray matter volume and gray matter density. We have the input, we have stain model, and we have Inception ResNet A, we have reduction, we have Inception ResNet B, we have reduction, and we have Inception ResNet C, and have average polling, and job board, and the software max. And this is basically the structure. If you don't quite understand, Sergio has already told you, and maybe you can ask him more about the building blocks, or ask me, or ask Dr. Binglu. So we have this kind of Inception ResNet module. It's pretty deep, and we're using TensorFlow and Keras. And if you're interested in, because all our code is publicly available at GitHub, so you can learn from our code how we trained that. And we have 4 NVIDIA Tesla V100 GPU. So this is our model. So we trained this model. If you're interested, you look at our code, how we build this model, and what this deep learning model can do. So first, we train a sex classifier. And what we want to do is we really want to use the cross data set, 5-fold cross validation. That's the whole data set, or the whole scanner have never entered into the training sample, so it's only in the testing sample. That's to make sure our classifier can work on new data set or on new scanning set. So we don't want to use a random 5-fold cross validation. So what we achieved is for brain sex that we have accuracy about 94.9%. And the AUC is about 98%. So actually, the model, we have the confidence that across the board, no matter what kind of races, no matter kind of what scanners, we have 95% confidence to tell you the sex of this brain. Although with our own eyes, we cannot tell the sex from the brain image, but the deep learning classifier can do. And we also trying to understand what the most important part of the brain to determine our brain sex. And Paul has already told you occlusion can do that. We cover some area of the brain and we see the accuracy. If the accuracy drops a lot, that means this area is pretty important for telling the brain size. So we found that in the brain size, the HPA, the axis, and the hypothalamus, it looks like a lot. And the most important part, like amygdala, this is the previous studies has already told you that this might be important for sex, but this is the model we'll look at here more and determine the brain size. And so the brain size, there's lots of previous literature talking about for example, the homosexual, heterosexual individuals related to HPA or the hypothalamus that on the biology. So this is a kind of validation on our classifier. And we're also interested in one thing. Because our classifier only have 95% accuracy, what happens to the 5%? And this is extremely sensitive, and I don't want to interpret. I just want to let you know some results. Because we think we have 5% of people, we cannot tell the accurate brain size. So we thought that might relate to sexual orientation. But it's not that obvious because we found in homosexual men, heterosexual men, the classifier is still pretty accurate. And in the heterosexual female, still very accurate. But only in homosexual female, the accuracy drops a lot. And we also examined the sexual identity. So there are lots of females, and then we also look at some transgender data. So biological female, they think they are male, and their brain is actually a male brain. So we don't know why, but I just want to tell you results, and this is a lot of place important to identify the brain size. So we are still working on that, but this is very sensitive. We haven't published it yet. And then another thing related to sex is there's always a hypothesis, the hypomale brain in autism. And we do look at a bad data. In a bad data, really that for the autism girls, their brain will look more like a male brain. So it seems the hypothesis that the male brain hypothesis is kind of supported by our brain sex classifier. But on the other hand, on depression, because we have big data on depression, or we built the rational MDD, is on the other hand, seems more male depressed patients, their brain seems more female-like. I don't want to interpret all the results, and it's pretty sensitive. I just want to show you the results. But build from here, maybe we can have more explorations. But this is still need a future work. However, sex is interesting, but it's not that clinical useful. So we still want to build for practical use. So from sex, we want to transfer learning to a Alzheimer disease classifier. We use transfer learning. We replace complex high-level neural models with simple convolution pooling models. And use this way, we trained on male and female, and then we do transfer learning to Alzheimer disease and the normal controls. And again, what we want to do the model validation is still cross-set five-fold validation that the single set has never seen in a training data set. And what we achieved is in ADNI data set, AUC is 96%, the accuracy is 91%. So we can tell you this is Alzheimer's disease or normal control. And that we have independent data set validation. So we never seen AIBL or MIRIAD or OASIS dataset. And all of these can be tested over 90% accuracy on this independent dataset. So that means our classifier can apply to new unseen dataset. And this is some other validation using sex classifier are using the age prediction to do transfer learning, and almost all can achieve good results, but the one we choose has a higher accuracy. And Alzheimer's disease classifier is not that interesting because once jump to Alzheimer's disease, there is currently not too much cure. So we want to see before Alzheimer's disease, for example, at the mild cognitive impairment, who will develop into Alzheimer's disease and who won't. And this is ADNI dataset that have the MCI and follow up, and who will develop AD and who will not, still remain MCI. So all classifier can tell you. So the classifier don't know the concept of MCI. And it just tell you that 3 times that 60.2% of those programmed MCI will be detected by all classifier, and who are not converted has very low risk. So that means our classifier has the ability to predict future progression, to predict Alzheimer's disease, the risk. And also this is can much better predict than the MFC. If you use MFC, cannot do this conversion and non-conversion prediction. And also we tried to use PET data to validate all scores, and all scores are pretty correlated with the PET SUVR score, because all score is also is from 0 to 1 prediction. And you can set a cutoff compound, and you can also test the linear regression. And this is the interpretation of the Alzheimer's disease classifier. And Paul has already shown this, right? That actually, we don't know why the classifier looks the left hippocampus much more than right hippocampus. We don't know why, but it seems it do so, that the occlusion seems this classifier looks this kind of place more. But this is not quite interesting because we know hippocampus has a problem in Alzheimer's disease. This is once again confirmed this kind of observation. And the classifier do not know any concept of MMC, but its output correlated with MFC, the disease severity score. So that means, although the classifier don't know the concept of MFC, but the output has a biological meaningful. And this is our patent, but all the model and the code is open source. And because this kind of data set, we have very high accuracy and very high accuracy on independent data set. So we thought this probably have clinical utility. And this is our prediction in MCI. So next is we want to really prove it have the clinical practice usage. So we collaborate with Dr. Han Yin, and the classifier never see Chinese sample because it's built on ADNI. So we want to see first on Chinese sample, can it be work? And also didn't see Chinese scanners. So should it work on independent, totally new race, new scanners? And Dr. Han Yin's data set has neuroimaging, has cognition, has like A-beta p-tau, and have very long time longitudinal follow-up. So we really want to see who will develop into Alzheimer's disease. Can we predict at maybe 5 years in advance? So here is the data. First, we use a traditional method to see. Here has 420 sessions of normal controls, 300, this is subjective cognitive decline. It's a phase prelude to MCI, and Alzheimer's disease have 122. And we don't know this data, but we directly apply this data set into our classifier. We have predictions, and we have the scores, and we can use this AUC. First look at Alzheimer's disease and normal controls, and this AUC is not that impressive, but we want to make sure this is the cutoff point. The cutoff point is 0.39. So for Chinese data set, we will use 0.39 to screen people. If you want to screen more and use more intensive tests, you can lower this threshold. That the sensitivity will increase. So the sensitivity that in Alzheimer's disease, using 0.39 cutoff, 92% of Alzheimer's disease we can detect. But in normal controls, there are 27.9% will misclassified into Alzheimer's disease. But we really thought those 27.9 normal controls in the future, they will develop into Alzheimer's disease. So this is why the accuracy is not that high. And in SCD, there are 29.1% that will have high risk. And MCI has 63.2% has high risk. So if you look at a traditional group comparison, it will always be significant. This is totally new data set, never seen. And, but this is not interesting because this, although have group difference, but we really interested in individual classifier. Can we tell the true results? But it seems it's pretty informative that 92% of Alzheimer's disease can be detected, and in normal controls, only 27 will have high risk. And what we're really interested in is not a current stage. We want to predict the future risk. So how much earlier can we know and hide? So this remarkable data set has longitudinal follow-up. So they followed the normal controls. There's 2 subjects later went into Alzheimer's disease. In the SCD, 2 went into Alzheimer's disease. And in MCI, that's 56 participants developed into Alzheimer's disease. So the important thing is, can we capture those? And so at the baseline, normal controls or SCD, so what we want to do is all those 2 has high risk. All those 2 has high risk. And in this 56 or 48 have high risk. And we know there are still lots of people we have high risk. They didn't develop into Alzheimer's disease at current, but we highly suspect those participants in the future, they will develop into Alzheimer's disease. And this is, we can catch. So there's a 60 individual progress into Alzheimer's disease, 52 we can capture at the baseline. So the overall capture rate is about 86.7%. So this is that we can capture, although none of this is Alzheimer's disease, but if they have high risk, probably they will develop into Alzheimer's disease. So this is what usage or all clinical value of our classifier. And we want to know how early we know those people will develop into Alzheimer's disease. So this have data set for those people we are developing Alzheimer's disease. They have more than 10 years ago, and 9 to 5 years, and maybe 4 years, 3 years, 2 years, and 1 year. So those is a distribution of the patients per the years follow up, the developing into Alzheimer's disease. So we group into 15 to 5 years, 5 to 3 years, 3 to 1, 2 to 1, and 1 year. So these participants, they will have Alzheimer's disease progression. So we want to know how early we can detect them. And here is for in the 1, 2, or 3 years, within 3 years, about 90% who we are developing Alzheimer's disease, we can detect they have high risk. Even before 5 years, 60% they will captured have high risk. So since this has high ability, we don't know why, because deep learning is really difficult to interpret. We don't know how, but it can tell you in the future if you have high risk. So we can have early intervention. And this is the sigma risk score that you will see as the closer to Alzheimer's disease, the score increased. So this is the utility of this. And also we do a survival analysis. So for this, this is normal controls, and this is SCD, and we look at MCI. So for those who have a high risk, most of them will drop into this kind of Alzheimer's disease, but a low risk, less drop into. So we think we have this kind of ability to capture if this will develop into Alzheimer's disease. And also, our Alzheimer's disease score has lots of correlation with the MFCE, with the CDR, and also have a correlation with the p-tau 181 and the p-tau 217 and the NFL and like that. So the classifier don't know nothing about this, but it do have a value related to the biological test. And another interesting question is, if there's a patient, you tell him that you have a high risk developing Alzheimer's disease, there's a simple number, probably not quite satisfying. He may ask, what's wrong with my brain? Which part of my brain has the worst risk? So we developed new algorithm to do the regional risk detection. So first we develop a template. This template, we average from Alzheimer's disease normal controls. If we feed this template into all classifier, it will have a 0.5 risk. So in the middle, 0 to 1. And then for an individual subject, we can fill in. We can get one small part of this individual, fit into this template, and we will see if this will increase risk. If a sport fit into this kind of average template, 0.1 template, significantly increase the risk, we will tell you that single subject, this area is a highly risky area. So this we developed, we can tell you the individual risk of different subjects. So which brain of you has highest risk close to Alzheimer's disease risk? So here is the normal controls, MCI, and Alzheimer's disease, and we see this hippocampus has lots of risk in developing Alzheimer's disease. And when we look at individual risk, the maps, it seems have 3 different kind subtypes. So these different people have lots of hippocampus damage, and this bilateral hippocampus damage. And for these kind of people, they almost have no hippocampus damage. And we highly suspect, because Dr. Han Ying's data is using behavioral assessment of Alzheimer's disease, we highly suspect these Alzheimer's disease patients, they are not AD. They are probably due to some other mechanisms, but behaviorally, they diagnose into AD. So we really hope in the future, if you have next data, you can collaborate to test this individual risk map. So this in the future may be better than breathing. Okay, so this is individual map. And for the individual map, we can also look at this is normal controls, and this is SCD, this is Alzheimer's disease. So you will clearly see for the individual risk, the Alzheimer's disease, you will see the hippocampus itself has very high risk close to Alzheimer's disease. So this is the score. And you will see this is low risk because they are not Alzheimer's disease, and the regional map is also have low risk. But this is 0.6 risk of Alzheimer's disease and 0.78 high risk, so you will see in the individual. So maybe in the future, we will show the patient, first, your risk score, second, your individual risk map of your brain. And if you have high risk, probably you should go intervention earlier. And here we can show you progress. So this progress, this subject at MCI and eventually went into AD. So we will see at the beginning has pretty low risk, but close to AD, then the risk increased a lot and above our threshold. And this is another, another also has always high risk and develop into AD, the high risk in individual maps. And this also, we can see the development. So in the future, at a different kind of stage, if we scan the brain, we can input it into our classifier to tell you the risk and also the regional risk. And as this, we have the opportunity featured in Nature News, so we want to have much large-scale collaboration to validate if this can really used to help neurologists. So we want to call the bigger collaboration. So what you need to do is you do not need to share your raw data. So you can use our model locally, have a prediction score, or use our online classifier has a score, but you have your own behavioral assessment. And you do not need to share your real data, just share the preprocessed data, and we see the score, how the score is. And would that helpful for your own study or for your own clinical practice? And our collaboration is you just share the output scores and the diagnosis labels to us. So we want to make sure more confident that our classifier really works. But also, if you are more interested in deeper collaboration, you can share the SPM or DPAS segmented WC1 or MWC1 and diagonal label us, that we can do even bigger data training or transfer learning. Or if you don't want to do any pre-processing, you can share your raw T1 images and diagnostic labels with us. And in the future, we can have the free training, data processing, we can co-author papers, and we can have priority access to a new model optimized. And if you're interested in how to use our model, please join us for the afternoon session that I will show you how to use our online classifier. So you have no programming skills. You use it all online classifier, brainimagenet.org. That's a very fancy domain name. So that you can upload you C1 or C1 or even raw T1 images to get the score of brain sex and brain Alzheimer's disease risk. So if you classify your own brain as a wrong sex, please let us know. Really curious why the classifier failed on certain kind of people. 95%, so only a small fraction of people will have a wrong sex of the brain imaging. And also, if you want to use our local GUI, so if you download our software at DPIB, it have a module of brain ImageNet, so you can predict locally. You do not need to have any programming skills because all the model codes are embedded Docker, and the software will pull the Docker file and predict at the local. And you can check all of our code at GitHub Brain ImageNet. And I will show you this afternoon, if you have programming skill, how to utilize our model and how to use our pre-trained model to do transfer learning if you have the programming skills. So finally, I would like to thank our lab. And Binglu, please stand up, let people know your work. So if you have any questions, ask Dr. Binglu. And I would like to thank Javier and thank Paul for the insightful suggestions. And another advertisement, mostly for Chinese people, that we are recruiting our institute. You can join our forum. We will cover your RTKs, cover your accommodations. Please please join our forum. And you can scan the QR code to join. Okay, thank you very much.
Thank you very much. I think we have time for questions. If you have questions, you can actually come down here. Maybe we take 1 or 2 short questions.
For the sex classification of the transgender women, do you have data on whether the people were on hormone replacement therapy? It could just be like testosterone correlation.
You mean, do we have a test of the DNA for the?
No, not the DNA test. Were the female transgender, or I guess the male transgender people taking hormone replacement therapy? So were they taking supplemental testosterone? Because that could be a direct explanation of the differences that you're seeing.
I need to check that, but I want to tell you is the transgender men, transgender women different. So for the men, they think they are female. Our classifier still think they are men. Only for the female, biological female, they think they are men. The label is wrong.
I guess the point I'm making is might not just be about what they're thinking. Like the hormone replacement therapy could be having direct biological effects beyond just the correlation, not causation. I guess is what I'm getting at.
We do need to examine more and have even larger data set. Thank you very much for your question.
I guess